Hello, guys. Today's topic of the video is diarrhea. How do we approach a patient who comes with the complaint of diarrhea? First, we have to follow the diagnostic model. Whenever the patient is coming with the complaint of um, loose stools, we are going to divide it into acute and chronic. In acute, what can be the probable diagnosis? It can be gastroenteritis if the patient is having vomiting along with diarrhea, and it can be due to dietary. The patient has eaten something in his diet which led towards food poisoning. It can be the cause, and other thing can be antibiotic induced diarrhea. Then we have chronic diarrhea causes. It can be inflammatory bowel syndrome. um, it is very common in among women. And then we have drug reactions and another diagnosis, chronic infection. What are the serious disorders which should not be missed? Can be neoplasia, cancers, in which there is colon cancer, ovarian cancer, and peritoneal cancer. If a patient is elderly and elderly male, and he is having anemia, tiredness, and weight loss and diarrhea, uh, we can uh, we can suspect colon cancer in that patient. Then we have HIV infections can be suspected in the patient who are IV drug abusers. Then we have infections like cholera, typhoid, amoebiasis, malaria, and hemorrhagic strain of E. coli. These infections are suspected in the patients who have a recent travel history. Then we have inflammatory bowel disease, in which comes the chronic Crohn's disease, ulcerative colitis, and then we have pseudomembranous colitis. And other another disorder which can be intussusception in young children who come with severe acute abdominal pain, and they have diarrhea, and they can also complain of red currant jelly. These interception can be suspected. Then we have pelvic appendicitis. Can also be the cause of diarrhea. Usually diarrhea is not the symptom of appendicitis, but in pelvic appendicitis, the diarrhea can one of the symptoms. Then we have pitfalls, the disorders which are often get missed. These can be celiac disease, especially in the patients. It can be suspected if the patient complains of whenever he has wheat and he gets diarrhea. And other systemic manifestations are also there in celiac disease. Then fecal impaction in the elderly and bedbound patients, they can have fecal impaction with spurious diarrhea. Then the lactase deficiency can be there, and some infections like giardia, listeria, and cytomegalovirus in immunocompromised patients. Then we have malabsorption disorders like celiac disease, tropical sprue, and other disorders that come under malabsorption disorders. Then we have nematodes infection, and there is diverticulitis in the males, especially after 40, 50 years of age. And then we have due to decreased intake of fiber diet, the patient can have diverticulitis. And then we have ischemic colitis. It is also suspected in the elderly patient who have a history of recent thromboembolic event. What are the disorders that can come under seven masquerades? It can be due to diabetes, and diabetes can one of the cause if we dig in. And then we have certain drugs like metformin, and then thyroid and endocrine. The patient can have hyperthyroid disorders. What are the red flags along with diarrhea? If a patient complains of weight loss, unexplained weight loss, and there is persistent unresolved diarrhea, and there is blood in his stool, the patient is having fever along with the diarrhea, overseas travel, and severe abdominal pain, family history of bowel cancer and Crohn's disease, These can be the red flags if a patient is coming to you with diarrhea, and you have to look these red flags in these patients. We can suspect certain disorders just by looking at the nature of stools. For example, if the patient is complaining, is having small volume diarrhea, we can suspect a large bowel disorder. It can be the inflammation or carcinoma. Then we have if the patient is complaining of large volume diarrhea, it can come from small bowel disorder. If the patient is having profuse bright red bleeding, and also other signs and symptoms are pointing towards carcinoma and diverticulitis, and the patient is elderly, we can suspect these two disorders. If the patient is having mucus along with diarrhea, we can suspect inflammatory bowel disorder, a non-infectious diarrhea, and there is mucus and chronic diarrhea, we can suspect IBD. If the patient is having steatorrhea and the stools are pale, greasy, and they floats over the surface, and they are difficult to flush, and they are increased with fatty meals, it can point towards malabsorption syndrome. Then we have rice water stools. Rice water stools are just like the rice water, and they are so severe that the patient becomes dehydrated in a few moments, and the patient we can suspect cholera. Then we have pea soup diarrhea, typhoid. It can point towards typhoid. And then we have watery, offensive, and bubbly diarrhea. Bubbly diarrhea, if the word comes bubbly diarrhea, it can point towards giardia. If the patient has these stool in the form of pellets, it can be IBS. And in large bowel diarrhea, there can be blood, mucus, and there would be urgency and tenesmus, especially if there is a case of carcinoma and IBD. Some special diagnostic triads we have to keep in mind, and they can aid towards certain diagnoses, are like if the patient is coming with acute diarrhea and he has acute abdominal pain and also vomiting, it can be acute gastroenteritis. If it is diarrhea and with blood and mucus, and there are cramps, it can be inflammatory bowel disease. Then, if along with diarrhea, blood, and mucus, and there are constitutional symptoms, and eyes and joints are also involved, it can be Crohn's disease. If the stools are pale and they are bulky, offensive odor, and they are floating over the surface, and the patient is also complaining of weight loss, it can be malabsorption syndrome, one of the malabsorption syndrome. If the patient is having fatigue, weight loss, iron deficiency, and there is bloating, it can point towards celiac disease. If the child is failure to thrive, and the recurrent chest infections are there along with diarrhea, it can be cystic fibrosis. If there are altered bowel habits, diarrhea, or constipation, between diarrhea and constipation, and there is rectal bleeding and discomfort, it can point towards carcinoma, and anemia also would be there. If the patient has altered bowel habits, abdominal discomfort, and anorexia, and the patient is elderly, confused, it can be fecal infection. If there is a profuse watery diarrhea, cramps are there, distension is there, and the patient is on antibiotics, it can point towards pseudomembranous colitis. Okay, what can be the diagnosis of diarrhea in elderly patients? Ischemic colitis can be there if the patient is having sharp pain with bloody diarrhea. On examination, on auscultation, there would be bruit on central abdomen. On barium enema, there would be sign of thumb printing, and other signs of atherosclerosis can be there in that patient. So we can suspect ischemic colitis. in elderly patients, and there would be fecal infection can also be another diagnosis. Then we have in children, what can be diagnosis? There would be acute gastroenteritis, infective gastroenteritis, food allergies would be there, antibiotic induced diarrhea, malabsorption syndromes, and overfeeding, diarrhea due to overfeeding. Chronic diarrhea in children can be due to lactose intolerance, cow milk protein intolerance. Cow milk protein intolerance can be rapid or delayed response. Chronic enteric infections, celiac disease, and cystic fibrosis. On moving forward with diarrhea, when coming towards traveler's diarrhea is also one of the very important causes of diarrhea. Who have a recent history of overseas travel, it is mostly due to E. coli, and there would be watery diarrhea within 14 days of return from a foreign country. If the diarrhea persistent and there is fever, blood, and mucus, it can point towards amoebiasis. And if there are cramps and flatulence and severe and bubbly, foul-smelling diarrhea, it can be giardia. Sometimes some diseases have a certain non-specific symptoms. For example, celiac disease. Celiac disease often misdiagnosed, as most of the times it is only um, presented to you with the complaint of tiredness. The GIT symptoms are not present there. So when we are So when we are investigating tiredness, celiac disease can be one of the causes. Tiredness due to iron deficiency anemia. There would be fatigue, and there can be weight loss. And if GIT symptoms are not present, uh, it can be celiac disease. Whipple disease is also it is a malabsorption disorder, and it can involve heart, lungs, and CNS. It is a infective malabsorption disorders actually. It affects more males more than 40 years of age. Chronic diarrhea. It causes chronic diarrhea, staturia, and arthralgia would also be there. Migratory arthralgia, and weight loss, lymphadenopathy, fever can also be there. On biopsy, there would be stunted villi. Coming towards the inflammatory bowel disease, when we are going to suspect inflammatory bowel syndrome in bowel disease in a patient, we will consider this disorder when the patient is young, and he is presents to you with bloody diarrhea, and mucus is also there. There is colonic pain and fever. Sometimes fever, not specific acute kind of fever, but low grade fever. And there would be urgency and incomplete defecation, feeling of incomplete defecation. And constitutional symptoms can also be there, like malaise and weight loss. Extra abdominal symptoms can also be there, like would be there, like arthralgia, low back pain, spondyloarthritis, in which signifies spondyloarthritis. And then we have eye symptoms like iridocyclitis, liver disease, skin lesions. So these are the extra abdominal signs and symptoms which would be there. And if all these symptoms and some of these symptoms are present in a patient who is young, and he is also have family history, we can suspect inflammatory bowel disease. So main differentiating points among ulcerative colitis and Crohn's disease would be: ulcerative colitis has mainly bloody diarrhea, and they do not exceed ileocecal valve, mainly involve colon, and the carcinoma risk is increased in ulcerative colitis. In Crohn's disease, the main complaint is mainly abdominal pain, while in ulcerative colitis, their main complaint is bloody diarrhea. In Crohn's disease, there can be right iliac fossa pain due to ileocecal valve inflammation, and perianal lesions and mouth ulcers are a feature of Crohn's disease and not ulcerative colitis. So when the patient complains of altered bowel habits like the alternating diarrhea and constipation, it signifies incomplete bowel obstruction. Incomplete bowel obstruction can be due to carcinoma and diverticular disease, or either inflammatory bowel syndrome. These two are the causes of alternating bowel habits. In the inflammatory bowel syndrome, would be there would be women who are younger and cramping abdominal pain, variable bowel habit, and most of the times the pain relieves with defecation or passing gas, and it is mostly precipitated by eating. It is often precipitated by eating often. Eating often, and if there are any stress going on, IBS can be there, and anorexia and bloating. These are some of the signs and symptoms of IBS, and stress can be the triggering point for IBS. If diverticular disease is mostly present in the patients who lack fiber in their diet, and it is usually symptomless. It is presented in more than 50, 40 years of age, and it is usually symptomless. But if the diverticuli get infected, it is called as diverticulitis, and it will present with symptoms like diarrhea, bloody diarrhea, and left iliac fossa pain. When we are going to refer the patient to specialist when he is coming to you with diarrhea, in children, if the child is infant and he is less than 3 months and he is having loose stools, moderate to severe dehydration, diagnosis of diarrhea and vomiting is in doubt, like there is blood or bile colored vomiting, and there is high fever, the patient is failing to improve, there is pre-existing chronic illnesses. So we in the on these conditions we are going to refer the patient to a specialist. In adults, if the diarrhea is chronic and it is bloody, and the colonoscopic examination is to be done for diagnosis. A patient has anemia, weight loss, mass on palpation. You are suspecting carcinoma. There is anal fistula or antamoeba histolytic infections, and IBD, which requires immunosuppressive therapy, inflammatory bowel syndrome with sudden change of symptoms. So these are some of the points on which we have to refer the patient towards a specialist. So this is the basic approach for diarrhea. I have not mentioned all the common diseases, signs and symptoms. Actually, I have mentioned how to approach the patient towards with diarrhea from John Murtagh.